And I would like to give this presentation in somewhat of interactive and participatory way, because the topic of healthcare quality is not really new, but it's, I have to admit, a dry subject, and to keep attention of everyone, participation will be good. And we will be doing it in Urdu and in English, both ways. Now, therefore, the first question is, my question is, do you know someone, either a relative or a friend, or you've heard about in after dinner, खाने के बाद बैठते हैं, so most of the time, people are coming up with stories of horror, and then the competition starts. It's like war rooms. One tells a story and the other one, does one up on it, and so on and on. So my question is, by raising a hand as to if you know or heard of anyone who died of medical error, either suffered harm, or as a doctor or a paramedic worker in hospital have witnessed an error being committed. So three questions. Heard of harm, know somebody, or actually watched harm being done? All three. So, which means that the harm is being produced in healthcare institution. The other issue is really that of resources, not only the resource of the patient, but also resources in public for the public. And we know that there is shortage of resources, which is a big issue, and therefore causes more harm than good. Same patient, or different, possibly different diseases, or even the same diseases, sharing the bed is the last thing that you want to do in terms of infection control. Crowding and free access of individuals of all kinds coming into the patient care area is not conducive to a good quality care. Commonest error in medication is wrong doses. Wrong dose starts from the doctors not being able to, or the nurse not being able to explain to the patient how to take the medication, just like the minister said, and not to explain to the patient when to stop, when to start, etc. And very carelessly, the prescription will write 1 + 1 + 1 + 3, 1 + 2, and therefore the patient will not fully understand how the medication is taken, irrespective of the fact that the pharmacist may dispense wrong medication because of the inability of the pharmacist to decipher the secret code of prescription of our doctors. Wrong patient, wrong side does occur, but remember that it occurs maybe once a year in the whole country, but once a year is also too much. It should not occur if the processes are followed every time in every patient, because you don't know which patient is going to suffer the consequences of the negligence. Surgical site infections. For elective surgery, there is no place for surgical site infection. Elective, clean surgery has no place for surgical site infection. It has been shown that at least 50% reduction in surgical site hospital-acquired infection occurs in those hospitals where simply the people will wash hands. And a recent report from Sri Lanka is that 70% reduction in surgical site infection. But washing of hands is important, but the washing of hands has its own process. And the process is 7 steps of washing our hands Professor Nabil Rahman and Mrs. Rahman showed us in our educational seminar as to how to wash hands. Just washing hands like this once or twice is not good enough. There's a certain way of washing hands. Not scrubbing for surgery, just washing hands to disinfect our hands. But now lately, the alcohol or the sanitizers have become available, and that should be used every time you go and touch a patient, and every time after you come out of touching a patient, because infection will spread through the hands of the healing hands of the physician, will actually give disease, which is such a big paradox. Non-compliance to the processes. For example, we have all heard that certain such harm occurred because the oxygen cylinder ran out of the oxygen and the patient suffered from a lack of oxygen. Because the oxygen cylinders are probably not checked, probably not properly labeled, and probably replacement is not easily available. Not only oxygen cylinder, this is true for many life-saving drugs that in emergency they may not be available. Transfusion is a huge issue, especially in our country, where transfusion error can cause deaths. And unfortunately, the commonest transfusion error is clerical error, where at the time of collection, there is an error in recording. At the time of storage, there is error in recording, for example, of the expiration date. At the time before giving the transfusion to the patient, there is wrong identification of the patient or of the blood type. And this is well known and totally avoidable. Mother and child death. Multimedia बंद हो गया. तो I think there is a message in this, and the message might be that we should maybe speak in Urdu. And multimedia. Any? Anyway, the next slide we were talking about mother and child health. 89% of pregnancy-related deaths are preventable. 89% of pregnancy-related deaths are preventable. 90% of the fetal death are due to 3 causes which are preventable. And these are infection, asphyxiation, and poor preterm evaluation. All of these 3 causes, 90% of causes are we are here. Thank you. And then we hear about horrible incidents. I mean, really horrible incidents. Such so and so that it is shameful for us to admit or describe. Ventilation switch. Unfortunately, and I hesitate to say, from a poor patient who's on ventilation, because a rich patient or a VIP requires, and the shortage of ventilations, you switch it from between one and the other. It has been recorded that nurse forgot to take off the tourniquet from a child's hand for hours, and the hand had to be amputated. And the worst of all that I've ever heard, that a cat ate an infant in leading teaching hospital in Pakistan. And I think unless we identify these horrible situations and we address them, we are not doing service to anyone. Now, the statistics of harm. What are the statistics of harm? This has been stated by the president of the Pharmacists Association in a conference. 500,000, 5 lakh log die of medication error in Pakistan. Estimated by 850,000 8 lakh medication errors occur in the UK, it's estimated. 2 lakh, 2,51,000, 2 lakh log died in the US of the medical errors in 2013. 4.8 million people died in low and middle income countries because of the poor healthcare quality. And these are not small numbers. But the paradox of all this is that all of us, medical healthcare staff, are highly educated and highly trained, cream of the crop. They're highly dedicated because we take the oath and our religion and our social values demand that we provide dedicated service. And we come in the morning, go to the work in the morning, सुबह हम काम पे जाते हैं to do good work and do the right thing. But why all these still causing harm to the patients? Because good intention or oath taking is not enough. It requires good quality service, requires skills, training, and through application of quality sciences. And let's compare two high-risk industries, aviation and healthcare. Aviation is high risk. You make an error, you can kill hundreds of people, healthy people. In healthcare, you make an error, you can kill one person, or if you make a big error, you can give HIV to a large number of people. However, the airline industry perhaps is a higher risk industry compared with the healthcare. So what are the statistics of airline industry versus healthcare? It has been reported in BMJ in June 2017, British Medical Journal, that 251,000 people died of medical errors. Third leading cause of death in America, by the way, this is one of the questions on the questionnaire. Third leading cause of death in America are heart disease and cancer. And it is only recently that the data about the errors is being owned, recorded with the cooperation of all healthcare workers, producing the result of the environment where making a mistake is no longer something that we should hide. Making the mistake becomes a culture opportunity for learning. You make a mistake, you make a near miss, then you sit down and discuss it amongst your colleagues and say what action should be taken for such thing not to occur again. So in 2013, 251,000 people died medical error, while in 2013, 224 passengers died from airline accidents. You see the difference? How did the aviation achieve this safety? It is not just by good intention. It is by training, and training. Anticipate errors and error-prone scenario. They discuss the scenario, failure mode analysis. What if this happens? What should we do? What if this happens? What should we do? They step each and every action that takes place is laid down as a called process. A process is step by step doing something for a certain end. Educated the workforce. They acknowledge the mistakes and they did the repetition of good or correct action. They destigmatize mistake. Now this is very important. Destigmatize mistake means that if our culture, we have two things in our culture. We never make mistakes and we know everything. there is difficulty in us saying, I don't know this, or difficulty saying, or impossible for us to say, I made a mistake. Destigmatizing mistake is one of the pillars of healthcare quality. Feedback, telling people and asking for feedback. How did you do? How did I do? And accepting the feedback with honor and with dignity and with full trust. And no repercussion for disagreement. If, for example, a co-pilot tells the pilot that this is how it needs to be done, it is mandatory on the pilot to listen to his juniors. God forbid, in our society, a house surgeon can tell a professor, sir, do it this way or the other way. It will end the career. Now, how did the airline industry reach where it reached? And the airline industry is not the only industry that has reached the pinnacle of quality. We know Toyota, for example, makes better cars. Mercedes makes better cars than others. Other quality institutions in Pakistan, for example, UHS is a quality institution in Pakistan because the leaders of the UHS brought this institution in the environment of quality consciousness. It all started early in early 1900, and these people who have done the work early in 1900s, Walter Short and Edward Deming, they are responsible for the industry improvement of quality in, let's say, Toyota, Bell Lab, or aviation. They defined the processes of quality, took away discretion or even thinking deeply at a point when the process has started. Now, this industry continued to evolve and get better until in late 80s, the industry experience was translated to healthcare. Industry experience translating into healthcare was done by Donald Berwick. This gentleman is still alive. He's in Boston, where I'm working at this time. He started Institution of Healthcare Improvement, IHI, a very, very famous institution. And he broke down the work of a hospital into processes, into protocols, into predetermined steps for a given indication, given disease, or given treatment. And as a result of this, many healthcare quality improvement regulation bodies emerged in the world. For example, Punjab Healthcare Commission started in 2012. Joint Commission International, JCI is one of the questions. Joint Commission International started in the U.S. Before Joint Commission International, Joint Commission for the U.S. itself started, and the job of this was to go and inspect the quality of the institution. Remember that PMDC will accredit the doctors, while the Punjab Healthcare Commission will accredit the institution that delivers healthcare, and that is the quality control of both the doctors and the healthcare institution. Before the Punjab Healthcare Commission, there was really nothing that regulated the institution. There is a large organization in the UK, the Care Quality Commission. Again, it's been charged with the same kind of work. So what is the function of regulatory body? Regulatory body issues standards. They say, okay, you're going to do these things in such and such way, and then those standards are given to the institution and say, you get ready, we come and inspect you, and if you pass, you will continue to function. If you fail, we can shut you down. And Punjab Healthcare Commission has 30 standards and 162 indicators, for example. By the way, this is one of the questions also. And so similarly, every regulatory body has a certain number of questions and certain number of indicators. For example, it will say operation theatre. Operation theatre, how the operation theatre will function. What will be the infection control policy in Operation Theatre? What will be the clothing of the doctors and anybody who enters into the operation theatre, etc., 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 all geared towards patient safety. Now, the healthcare quality is not only part of the national health national agenda, it's also part of the World Health Organization agenda. Attention is being paid to healthcare quality in very big way. And as you know, that the WHO came out with 17 sustainable development goals to transform the world until 2030. 17 sustainable goals. And goal number 3 out of those 17 goals are to ensure, this is the word to word taken from there, ensure healthy lives and promote well-being for all at all ages. And this indicates that there needs to be an effort to make for all ages provide health care at a certain quality. Remember, very important, if you don't measure, no measurement, no improvement. Unless you watch somebody, unless you measure, unless the data is available, you will not know whether a certain surgeon is doing a better job or compared to the other, unless you compare the complications. There will be if you take a group of actions and you want to see whether it is improving or it is getting worse, unless you show the data, impressions and subjects don't occur. Because impression will follow the most powerful person, their graph will always go up. Unless you show the data and show the objective analysis of the performance of an individual. And we know that performance under observation always improves. Performance without observation does not. Now, the fundamental question is, what is quality? We keep on saying quality, we keep on saying all the time. The quality is the intended characteristic or features on absence of variability, of error, that you do same thing the same way. For example, patient with chest pain suspected myocardial infarction enters the emergency department. A written protocol. First of all, give aspirin. Second of all, give call to the cardiologist. Third, do EKG. Fourth, get troponin. Fifth, sixth, seventh, eighth. And then if the EKG is ECG is positive and you show that the MI is continued, call the interventional cardiologist, interventional radiologist. Get the patient from door to the needle time, as you say, for catheterization and whatever is necessary, that either percutaneous angioplasty or stenting or surgery. So there needs to be protocol. Now, it has been shown that if you have a list of actions, there is several times more chance that the action will be produced and will be taken care of compared with leaving to the memory or the judgment of the people at the time. And therefore, and that's what the quality is. Fundamental quality improvement is, you know it, what should be done. The quality sciences